So today we're going to talk about three things. The first is going to be sort of what we call sort of the state of affairs, the state of the problem. The second is going to be, what are we going to do about it? And the third is how we can all go into our communities, to our friends, to our colleagues, as advocates, to make the business case for doing the right thing. And so I was with, actually, the American College of Cardiology earlier this morning, and one of the things that came up was, well, we know this stuff. First of all, it turns out they thought they knew this stuff, but when it comes to women, they don't always know this stuff. And the second thing was that no one understood that we can operationalize this. We can change the world. We can do stuff, each one of us, to change how we care for women. So the framework we'll use is pretty straightforward. And if you remember nothing else from this day, I ask that you remember this. And the first is count women, study women, care for women, include all women, and invest in women. So today we're going to count, we're going to study, we're going to care, we're going to include, and we're going to invest in ourselves and each other. So let's talk, where did we learn about this stuff? McKinsey, as a global consulting firm, has access to a lot of data and has a lot of friends, so that's the first part. And the second is through a partnership with the World Economic Forum. I just heard someone went to Davos last week talking about longevity. We have a partnership with the WEF for the Global Alliance for Women's Health. So that's where a lot of this research comes, the convening and bringing people together. So what is the women's health gap? The women's health gap is not the ideal state of health for women. It is the difference between men and women when it comes to disability-adjusted life years, so our morbidity and our mortality. Women spend about 25% less time in good health compared to men. And one of the biggest myths that I hear about this is that, oh, well, women live longer, so we must just be at the end of our lives not well. Turns out that's not true. Most of the time that we spend in poor health is in our working years. Over 50% of the gap comes during our working years. So what is the implication of this? Because you just set me right up here. I love that. It's GDP impact, it's productivity. Our workplaces are not designed for us to be women. They are not designed for the fact that when people have endometriosis, they have pain 12 times a year at least. They're not designed for menopause. They're not designed to really understand. They are very sort of, by the book, all of our workplaces. And so this means that we are not as productive when we want to be productive. We don't have the flexibility that we need. And as a result, our communities and our economy suffers. These are all, by the way, preventable and avoidable things, but this is the current state of affairs. And this is that $1 trillion number Selena mentioned. That is globally, every single year, $1 trillion would be added to the global economy if we closed the gap between women and men. So this is $1 trillion across the world. What does that mean for us as individual people? I don't really know what $1 trillion is. So, it sounds really big. It's clearly a lot of money. What that means for me personally is if we close the women's health gap, then I add 7 days per year of healthy life during my working years and beyond. That's over 500 days across the course of my life. That is a year and 2/3? So when we think about what does closing the women's health gap mean, sure, it means more money for the world, that's great, but it also means that my life is different, my life is better, and that I'm not in pain or suffering in the same way. And again, this is not even just like good health, it's just the gap to men. So over the last year, 2 years, I mean, we've been studying women since the dawn of time. Every single one of us in this room came from a uterus. So we know that this is something that's been on people's minds. But it's really in the last couple of years that I would say it's been mainstreamed. When Oprah starts talking about it, then people start listening, and that's great. And I think what this is again here's the problem, and people are starting to be moved towards action. And again, this group for 6 years has been doing extraordinary things in every single community in which there is a champion and beyond. And when we think about how do we get the world to change, there's starting to be some traction. So we know the problem. We are not as healthy as we could be, and many of the things that we are talking about are not, certainly some of them affect lifespan, so that's kind of the years of life that you have. But life to your years, or your health span, is really where we're gonna focus today. So if we're going to add years to life, amazing. But mostly, we want to talk about how do we add life to our years. So we know the problem. And so we're starting on this blueprint for a solution. And so you already know the answer. This is our count and study, care, include, and invest. And so what do we mean by that? What does it tactically mean to count women? One is it's improving our data collection methodologies. So globally, we can't tell you how many women die related to childbirth every year. We actually don't know. We have some guesses, but we don't know. It's not collected at a global level. We also don't know how many people have endometriosis. When we look at the global database, say IHME, which is this sort of one database, and you have the WHO, another database. Those are the two most accepted databases in the world, and they're off by an order of magnitude. They're off by 10x. So we can't even tell you. And what is the implication of not counting? It means, number one, that when we don't know, we can't act on. Number two, it also means that when people are trying to invest in this space, you make a business case, right? And you say, how many people have endometriosis, so how many people could my treatment affect? If you have no idea, or if you're not counting, you actually don't know an answer. So that's one of the first things we need to count. And so what does it mean, and what about study? So studying is conducting research into women's health. It's also things like, for all the trials that we do today, most of them do not sex disaggregate their data. And so when we think about, you're already doing the thing. This is just adding a column on your spreadsheet, right? This is doing an analysis on data you already have. And of course, there's a funding issue, which we'll get to in a minute as well. So sex is a biological variable, not studied in the same way. We don't use female rats, lots of stuff that we'll get to in a minute, or mice. On this care for women, we'll talk about a few things. One is around clinical practice guidelines. So for example, we know clinical practice guidelines set as a physician is what I look at, say, how should I be delivering care? Most of them in heart disease actually don't. I think it's less than 30% of clinical practice guidelines that we looked at around the world even mention that women might have a different treatment pathway or presentation. So when we think about what do we do for caring for women, first we have to use the evidence to set the guideline. And the second is our delivery systems were not designed for us. They certainly were not designed for women of color. And so how do we create a care delivery system that is not only more equitable, but is actually designed to deliver the result we want it to deliver? So then we have include all women, and this goes around the point about when we think about what does it mean to include all women, about 60% of the heart disease burden is in upper middle income countries, upper income countries, higher income countries, but 94% of clinical trials are conducted in those countries. So when we think about the burden compared to where we actually putting, and even within those, they still don't include women, and certainly don't include women of color at rates that match the burden. So when we say include women, it's in all the ways, around the studying, the caring, the investing. And on Invest in Women, it's across a bunch of different dimensions, but one of them is when we think about investments in startups, early stage companies. Less than 20 of the women's health companies early stage funded recently were focused around cardiovascular disease. So there's massive opportunity to think about when we're talking about women that each, go start something. There's a lot of opportunity there. So on the Count Women, we'll go through a bunch of things that hopefully, some of which you know, some you may not, but so we'll kind of level set here. So cardiovascular disease is not just a man's disease, as we all know. And so we've talked about what is the actual business case here. The gap is that if we closed the women's heart health gap in the United States, we'd have 1.6 million years of higher quality life for women in the United States, and about 28 million additional GDP from addressing heart health for US women by 2040. And I think that should be $1 billion, actually. it's a lot. We'll come back to this in a second. So when we think about the women's health gap, we're saying the gap between men and women. And so this is made up by about 64 conditions drive the women's health gap, but over a third of the women's health gap in the US is made up by cardiovascular disease. And this leads to, again, it's $28 billion and 1.6 million disability-adjusted life years in each year for women in the US if we close the women's health gap. So what are some of these challenges? So here's an example of why is sex disaggregating data good? Or I should say, when we don't sex disaggregate data, what's the problem? 8 out of 10 drugs that are recalled by the FDA are removed because of adverse effects in women. If you haven't sex disaggregated the data, you don't know what the side effects are. And if you haven't studied it in women at a proportion to which they might actually use the medication, then you're much higher risk of just not knowing what you don't know. And it turns out that medications are metabolized differently in women, they affect women differently, and they are not studied. An example I heard recently was that the GLP-1s, so the Ozempics, the Mounjaros, they were just studied on male mice, which is fascinating. And their early stage trials were all male mice. Well, I know a lot of women on Ozempic these days. I've prescribed it to many patients, and they all have side effects. I mean, this is anecdata at this point, so I'm just telling my story. But anecdata is the side effects, the nausea, the vomiting, the kind of fatigue, way more pronounced in women than it is in men. And that's not shocking because we didn't even study it. So when we think about women are more likely to die from men in a heart attack within 5 years, this is true. It's even higher for women of color, and it's even higher for younger women who present with cardiac disease. Women have been found to be about 50% more likely than men to be misdiagnosed following a heart attack. So one of the things that I wasn't today years old, but I was pretty recently years old when I really thought about this. So I'm a hospitalist. I take care of people who are in the hospital, many of whom have cardiac conditions. And it just suddenly occurred to me that typical chest pain is just how men present. And atypical chest pain is how women present. But we're 51% of the population, and we're just the medical students today are learning it's atypical. It's like, that doesn't even make sense, right? Of course we aren't diagnosing women, and it's not an individual physician's fault. It's not a health system's fault. We have designed the system to yield these results because we teach medical students that it's atypical to present without sort of the classic symptoms of substernal chest pain. Another thing is when we think about, so then I went down a rabbit hole, of course. So then we think about, well, what's in your textbook? The only time I can recall, and I could be wrong, but this is my med student brain from many years ago. The only time I can recall looking at a drawing of a female in any textbook that I ever had was because they were differentiating her reproductive organs, right? So when we look at the cardiology textbooks today, and I opened a couple, my husband's an oncologist, and I was like, I need to look. It's just, unless it's breast cancer, it is a picture of a male drawn out in every single book. We are creating this unconscious bias in every single person that we train in the entire healthcare system, that the typical is just a 70-kilogram white male and everyone else is just atypical. And we know that's not the case. And so it's not a surprise these are our outcomes. What is important is that we do something about it. This is about 60% of Black women over the age of 20 have some form of cardiovascular disease. And again, this is 50% higher than in white women. So we have a responsibility to ourselves, to our communities, to each other to change these statistics. Okay, so this goes to more about this gap. So we looked at, when you think about ischemic heart disease, hypertension, we've talked about, in some ways, around the things that why do these gaps exist. We have this care delivery problem. We have a treatment efficacy and effectiveness problem. So what I mean by that is treatment efficacy is how does the drug work in the clinical trial? Well, if you didn't study women, or you didn't have female mice, or you didn't sex disaggregate your data, treatment efficacy is one number. Treatment effectiveness is what really happens when you start giving this to people in the community. So these are things that are driving the women's health gap. And then we have data. We just don't collect stuff for the most part. So how do we study women differently? A few things. We know that there are traditional risk factors by gender that are just different. The second is that estrogen has a protective effect that we don't study as much as we could. There are some postmenopausal questions around this too, and that symptom onset just differs. So across life, whether it's in utero, these are some things that we know. We know that preeclamptic pregnancies have increased risk of cardiovascular disease in their offspring. We know that you have increased risk of cardiovascular disease after menopause. We still don't kind of know the whys or the biological mechanisms or the pathophysiology behind a lot of this, but we know that it exists. So puberty marks first major changes. Interesting, there's an association between adolescents who have menarche below 12 and then risk of cardiovascular disease later, probably related to metabolic syndrome, which is one of the reasons that menarche is less than 12. But the number of young girls that I know who have started their periods before 12 is growing, and we don't know the implications or all of the whys behind this. But we do know that the question is, does it predispose to future problems? Is it correlated with future problems? These are all things that those of you in the science space, I hope, start to spend your time, your resources, and your money on, is investing in understanding the why. Oh yeah, please take pictures. We can circulate all of these too. It's fine. Whatever you want. Again, this is correlated. We know that as estrogen declines, your prevalence of cardiovascular disease goes up. And the Menopause Society was on here earlier, so we should talk later. Much more on this, and a lot to learn here that we don't know as much about. The thing is, we don't know, and we're not gonna know if we don't start using some female mice, for one. So if we look at cardiovascular basic science research, 72% of today, 72% still only uses male mice in cardiovascular research. When we look at clinical trials, so this is 2010 to 2017, we looked, and I was curious, has it gotten any better? And it hasn't. In 2022 to 2024, 31% of trials open to both sexes. Only 31% of trials were open to both sexes, and of those that were, still women are underrepresented in the population sample size. So care for women, we're going to talk a little bit about pregnancy and preeclampsia here, and sort of some of these risks. So maternal mortality in the United States is increasing among all populations. Since I started medical school, maternal mortality for Black women has doubled in the United States. And the leading cause of these deaths are cardiovascular disease. And so when we think about most of these, at least 80%, I would argue that's higher, are preventable and avoidable. And when you talk about counting, some states now don't even count maternal mortality in the United States of America. And so when we think about cardiovascular disease as the leading cause of preventable maternal deaths, and we are one of the only countries in the world in our income level where this is actually growing. So it has lasting effects. I have a friend who's a cardiologist who studies women in Boston, and after I gave birth to my babies, he was like, I'm having a really hard time getting normal controls for my study. So he's like, I just need you to do a stress test at 4 weeks postpartum. Now, for all of you who have gone a cardiac stress test, 4 weeks postpartum is probably the least likely time that anyone wants to undergo this stress test. But even in I didn't have preeclampsia, even in my normal vasculature, there were changes that no one had known about before in normal controls. And then when you look at women with preeclampsia, they're lifelong changes. So interestingly, so again, kind of things that we do, women have better heart health outcomes with female providers. Women, when they have a male PCP, they're less likely to receive more aggressive risk modification. So it kind of goes both ways. We'll come back to this because, again, I think this is not a gender problem. This is a problem along the entire medical education. And the problem here is that 85% of cardiologists are men. It gets worse when you start talking about interventional and structural. So gaps in medical education, as you mentioned, our clinical practice guidelines in the United States of America score 1 out of 3 on their comprehensiveness for talking about and addressing women. So in the United States, our own clinical practice guidelines that are the gold standard for physicians across the entire country do not include sex-based differences along treatment pathways. And of course, not shocking, we're not getting taught this in school either. So what do we do? You know, it's our care delivery providers need to build a gender-inclusive workforce, implement gender-specific care protocols, research, and actually just talk about this among ourselves and each other. I was, again, at American College of Cardiology this morning. They said, oh, well, we don't enroll women in clinical trials just because they're pregnant. And I said, well, you also don't include them when they're postmenopausal, and those people are not pregnant. So I think that it's not a problem with your assumption that we are just pregnant and not enrolled in trials. So I think even amongst ourselves, that was about 7:30 a.m. So it's still happening today. We talked about inequities. So the Black women face the highest burden of cardiovascular conditions relative to their peers. So B is for Black women, and white is the D. And so they're 59% again versus the 42% we talked about earlier in the United States. And this goes to ignoring women is just really bad business. So when we talk about what is the intersection of good healthcare, good medicine, fiscal responsibility or business, and what I might say social justice or the doing the right thing, that's winning women. For healthcare providers who win women, they win their markets. And so they are just making are making bad health decisions, business decisions, by not caring for women. Women are way more sensitive to access and experience in their healthcare providers, and we're not studying them, we're not caring for them. But if we did, and when those providers do, they win market share. They win their markets because we talk and we tell each other, and all my friends are now gonna go to this other place that was nicer and better and cleaner, and I could schedule on an app, and that's where I'm gonna go for my healthcare. And it just has a really good doctor. I think. So what if we did this? We'd have a $28 billion annual economic boost in the United States if we close the women's health gap. So what do we need to do? This goes back to we need to count women and study women and care for women and include all women and invest in women. So with that, I think my time's up.